I'm going to provide for you a brief review of something that's really very exciting. Now, it's called e-ICU, and I'm going to take you just through a journey of why, for those of you who have not already, silence your phones. I'm going to take you on a brief journey of why this is so important, and it really starts with this image here. So it used to be when a patient was in the hospital, we didn't have a lot of equipment, and now there's more and more equipment. And, you know, there could be even more with this patient. It becomes increasingly difficult for one nurse to take care of somebody like this. It used to be that you could fly your airplane without a computer, but now, you know, with jet engines and so forth, you really need lots of computers to keep track of things, and it's become similar with patients. Obviously, not every ICU patient has this many IVACs and monitors and so forth, but there are other things. You don't see a balloon pump in this room. You don't see other things that could be in there, but it's complicated. In addition, even in the best ICU, you may have certain patterns of management of care that are different than another ICU in your same hospital. Nurses may go from one to the next, and you may have different processes, and so it takes a little while to understand, oh no, we're doing it a different way, and so that's a problem that causes patient errors. Another concern is this here. It's a very different place to be in a hospital on evenings, on weekends and holidays. If you just look if you look at the parking lot on a holiday where there's very few cars, those are the people that really need to be there, you know, that take care of the patients. But unfortunately, the knowledge and the experience of some of the others that are not there now allow patients to deteriorate and become ill, and we may not really act on them as quick as we would otherwise. So there's abundant data here. Critical care, American College Archives of Surgery, CHEST, New England Journal. We all have lived this. We all know this, but there's a lot of data to show it as well. So what we're going to be talking about here is having a awake person, a doctor and or a nurse that is watching patients while the attending is home asleep. And they can manage and be watching after patient deterioration a little bit quicker. And I'll get into that. You could say, well, we have nurses bedside already. Well, we have nurses, but they get task saturated. They get busy with one patient. Maybe they're covering for another one while they had planned on going back and emptying the urine and seeing what that output was. They had planned on checking the next lab data, but they got stuck now with this other patient that's deteriorating. So this other one now has a rising lactate, a decreasing urine output, a decreasing hemoglobin, an increasing heart rate, an increased respiratory, et cetera, and you may not act on. So if we have someone that can watch that for us, that's helpful. The other problem, of course, that we're aware of in, certainly in academic centers where I practiced most of my life is this problem where the nurses are afraid to call the doctors, and so are the residents. They don't want to be, they don't want to be a problem and a burden. And so then you get somebody who reinforces that behavior by, barking at them for this is really a trivial problem, et cetera. So this is really what we're going to be talking about. So you can have somebody who's awake, alive in person, watching, and this screen here is kind of interesting because there's a bunch of little round orbs there, and we're going to show a picture of what this looks like in a moment. Let me just pause to say, there are a number of automatic systems that have been developed to look at patients' flows and trajectories. The one that is probably the most robust is something that was called VisiQ, started by a couple anesthesiologists actually in Maryland, and then their system was acquired by Philips 7 years ago, but 17 years ago they started, refined it and so forth. That's the one we're going to talk about, but I want everybody to know that I don't get any honorarium from Philips. It just seems to be the most robust system. And but there are some others, and even with this Philips e-ICU model that we're going to talk about a little bit, I'm going to show some pictures from their system. It's not good enough. We have to add things. So we'll talk about some of the things that we have envisioned to add to it, and you might have some other ideas as well, and that's what this is all about, really bringing ideas together and seeing if some of the work that you're embarked on might have a role here. So if the patient is becoming unstable in the room and the nurse or the doctor or somebody wants to get attention from the e-ICU team, they can push this button up on the wall, just like if there was a code, but that get the e-ICU, get their attention. And then the e-ICU could beam in with a very high definition pan and zoom camera that's capable of looking at the pupillary response from across the room. It's really, a very nice system, and also a very high quality voice, so you can hear what's going on in the room as well as see it. And in situations where the patient is not super unstable, not coding, you can use the system just for basic rounding. You can have a physician or nurse at the command center that is going through, in this particular case, PT rounds. Just making sure with a group, and in this particular case, the individuals that are going around may not even be the head nurse or the bedside nurse, may be even an MA or somebody that's just doing a little bit of work that now is feeding this information back. So in lots of hospitals around the country, we may not have intensivists that are even in the ICU. And certainly many, almost none, have them 24/7 at night. Only a few do. And you can have a system where that person that is in the e-ICU command center is leading rounds with the charge nurse or somebody to go through and just make sure all the evidence-based protocols that you have already developed are in play and they're happening and getting feedback. So that's from one level to the highest level, where if there's a code in the room, this particular individual could be guiding therapy, and instead of seeing just a simple listening to lungs in a stable patient, you're helping to even run a code in a place where they wouldn't have that oversight. So there's a big spectrum. So essentially what we're trying to do here, this is population management, ICU population management, similar to air traffic control. Now the air traffic controller is not going to be calling into the cockpit of a commercial airliner unless they want to put them on a new trajectory. But if everything's going good, they're on the right glide path, they're at the right altitude, they're heading the right direction, right airspeed, they leave them alone. But if they find that they're deviating, now that's when they act on them. Well, this is what we're talking about with the e-ICU. If the patient now is falling off of their getting better trajectory, that again, the urine output's dropping, the heart rate's going up, certain laboratory data is becoming very worrisome, and then they check, and nobody's doing anything about it, now the e-ICU has the ability to write orders, has the ability to ping people, call people, get them in there, and take care of the patient sooner. So just as we're trying to keep all these airplanes from running into each other, we want to make sure that all of our patients in all of our various ICUs are on their getting better glide path. Does that make sense? And you can do this in your own hospital initially, and then you can do this for outreach. At our particular hospital, and I'm going to show you what our vision is in a moment, at our particular hospital, we're full, and we've been full for quite some time. And we're the tertiary quaternary center for sending difficult cases, but some of the cases that come to us, it's only because they don't have an intensivist. But the patient doesn't really need to come to us. So if we can now keep those patients at their outside hospital, have this system there at their outside hospital, and have our command center watch them, then they can be managed there and only come to us if they deteriorate further and need our care. So what we're talking about is leveraging a lot of computer intelligence, a couple ICU nurses, and a critical care doctor. And so the number of critical care nurses you need depends on how many beds you're watching and how sick they are. Now, if you listen to the company Philips, they will tell you, well, you can have 50 patients watched by one critical care nurse. Well, that's like you can ignore 50 patients as easy as you can 100 patients, right? So, but really, and I've visited a number of systems around the country, and we'll talk a little bit more about that. But it comes down to do it safely and to be able to really interact, providing you have great protocols in place ahead of time. Then it's about 35 or sometimes up to 40 patients per ICU nurse. And you can have one ICU doctor working with 3, 4, and up to like 5 nurses. Once you get beyond that and that spectrum of patients, you have to kind of add another one. Does that make sense? But also in here, I'm just showing the doctor-nurse ratios. You also can add a pharmacist. You can have a clinical documentation expert also. You can have, if it's a big enough system, you can have people with special expertise in maybe neuro or special expertise in cardiac, et cetera. So some of the things that you would be watching with this system are very simple. We call these, I mean, obviously low-tech things. We do this like just following the blood pressure, the heart rates, and so forth. And there's color graded. If it's red, it's not in the right range, and yellow, it's okay, and green, it's in a good range. And they can follow things like urine output, metabolic acidosis, lactate, creatinine clearance. Number of smart alerts will go off if the patient is out of normal range. Now, if you have a patient that comes in with renal failure already, then that's already in the system. You're not going to get alarmed because the BUN and creatinine are elevated. But if that patient now starts having elevated potassiums, now you will get alerted. And I talked a moment ago about the orb view. This is just one way of categorizing the patients. This is representing one particular patient. And if the square around the patient is red like this, it means the patient's not getting better. If it's green, they're getting better, and if it's yellow, it's kind of like they're on the verge of not doing that well. And then you can look in greater detail, and this particular patient has some infectious disease problems, there's hematological problems, and so forth. If the patient's been in the ICU for less than 1 day, the circle around here is blue. It's black in this case because the patient has been in there for 5 days already, 62-year-old patient with these different problems. Now, in the screen I showed earlier, there were a bunch of these pictures. You can push a button and boom, you can sort these patients to the sickest top left and the least sick down below, and you can make sure that you're rounding on those patients sooner. There are a number of algorithms for looking at readmission likelihood, and there's something so-called Discharge Readiness score that is derived. One of the good things about this system, and I'm going to say the bad things about it and the good things, because again, I don't get anything from the Philips system. It's just the work that I've done looks like it's the most robust. But this is the data that goes into this now is the world's largest ICU database. It's really the only one that has live feeds from hundreds of hospitals now. So you can get high-level analytics, with this you get Apache scores, you get some of the things we've all figured out how to determine our length of stay and all of that, but you can have printouts and graphs of exactly what your patient status is on an hour-to-hour basis. Make sure that your patients are on the proper protocols, they're getting their early entry nutrition, their early mobility, the weaning protocols, all of those things, make sure the patients are having that. So what's the data on this? There have been a number of papers, and one of the more prolific writers about this is Craig Lilly, and this is one of the first larger studies that was published in JAMA in 2011. And this was at a hospital, a number of ICUs at the UMass Memorial System, which has a number of ICUs very similar to what we have at UC Irvine. We have 68 ICU beds, 5 different ICUs, and they had 7 ICUs, but their total number of beds were about the same. And what they demonstrated was before having the e-ICU in place compared to after, they had a 20% decrease in mortality and a 30% decrease in length of stay. So let me just pause for a second. If, in general, when you have a study and you decrease length of stay, what does that usually do to mortality? If you decrease length of stay, it usually increases mortality because some of those patients that you're not keeping alive. And vice versa, if you do something where you're going to decrease mortality, well, you're keeping alive some of those patients who may be futile condition. Does that make sense? And so your length of stay tends to go up. But when you have a system where you decrease length of stay more than 20%, you decrease mortality more than 20%, now you have something that actually is worth talking about. And so why is that? And the answer is that the patients emerge from the ICU in better physiologic condition. And so one of the other things they showed in this paper was, look at that number, 80% decrease in preventable complications. So, and you know, they go into some detail about some of the various areas, but one of the more recent and really the biggest now published study of outcomes was this paper that was published in Chest in 2014. I have a 2017 data that I'm going to show in a moment that talks about the financial benefits, because everybody's like, well, how do you pay for it? Well, but first I want to talk about the quality and safety, because that's why I'm really talking about this. That's why it's really so important. So this particular paper, 56 different ICUs, 119,000 patients, 32 different hospitals, and when you looked pre and post, on average, mortality decreased more than 20%, what they showed before. It was 26% here in the ICU, and the length of stay dropped 20% in the ICU. When you looked outside of the ICU, it also decreased length of stay and mortality. Why? Again, because they emerged from the ICU in better physiologic condition, and they left the hospital in better physiologic condition. So this is these are very robust findings from a good peer-reviewed journal. And this is a forest plot of the same data. So on the top, we're showing length of stay in the ICU and hospital, and down below is mortality. And this number these numbers here are the ones that I showed, 20%, 26% decrease in mortality in the ICU and 20% decrease in length of stay. But as you can see here is that almost all the hospitals had a very robust decrease in length of stay in the ICUs. There were some that didn't do quite as well, but some did even quite a bit better. But it's not like, this is very significant data for length of stay, both in and out of the ICU, as well as the mortality. Now, a more recent paper looking at the financial outcomes, and this was just published this year, February, in Chest once again. And this was looking at that UMass 7 ICUs. They reviewed 51,000 patients over several years. And this is the schemata that they used to evaluate. They looked at cost per case, the number of patients that were going through, and length of stay at the beginning of the study, before they had the e-ICU in place here, then after they sequentially put it in place, and then they optimized their system by putting out a number of additional evidence-based protocols to further strengthen this. Now, we've done that work at UC Irvine over the last 2 years. We put in place 24 evidence-based protocols throughout the entire hospital, through all the ICUs, the CCU, MICU, surgical ICU, neuro ICU, burn unit. They're all doing everything the same way in terms of early mobility, early enter nutrition, pain, agitation, delirium management, weaning protocol, and you can go down the list. And so that is so that we can make sure that when we have not deployed this yet. I'm going to show you our deploy strategy. It's because of this great outcome data that we've seen, and now the financial data. So they looked at before, after, and then when they put the logistics center in, what their outcomes were. Their total number of patients on an annual basis through their ICUs before this was about 4,752. Ours at UC Irvine is about 4,500, so it's very similar numbers. And they were 90% full, like we're 90% full. When they deployed this implementation phase, they were able to increase the number of patients that they took care of right away. And then when they added the logistics center, they were able to increase the number of patients further. So how did they do that? By decreasing the length of stay, with a 38% increase in case volume when they were already 90% full. Now you recognize once you get above 85% full in your ICUs, it's like being on the freeway at rush hour. you have difficulty moving patients around. So it was this improved efficiencies, decreased length of stay, less complications, that they were able to do this work. Then they looked at the financial outcomes. At the orange on the bottom is the cost per case. So initially, when they put the system in, during implementation, the costs increase because there is a financial outlay to put the system in and some ongoing costs to pay for the doctors and nurses to do this. So their costs went up initially, but as they became more efficient, their overall costs were able to come down. Their margins, though, went up significantly. Year after year. It went up with implementation and then further with their logistics center. And so overall, they were able, they had an annual direct contribution margin from their ICUs of a little over 7 million. After the ICU telemedicine center was optimized 37, and when they got the logistics center optimized is up to almost 61 million. So they had a significant increase in the margin. So it saves lives. It's safer for patients. What else? It has a positive ROI, but what else? Here's the study looking at the malpractice claims in the ICUs for the several years prior. On average, they would spend $6 million a year on malpractice. After implementation, their average spend was $500,000. They did not see a similar decrease in other areas where this system was not placed within the same health system. Then you may ask, what do the nurses think? And it depends a little bit. If you don't deploy it properly, if you don't get good nursing buy-in from the beginning, then initially there's pushback, they don't like it. But then after they see it work, then they love it. But if you deploy it properly, then right from the beginning, the nurses are on board and they don't want to go without it because they know that there's some backup for them. It happens with so in California, we have a nurse to patient ratio of you have to have at least one nurse for every 2 patients in the ICU. And often they're very sick, like the picture I showed of the first patient, that's going to be a 1-to-1. And maybe you might need 2 nurses if you're starting to do some continuous veno hemodialysis there and all of that. You may sometimes need more than that. But we have, on average, we staff for a 2-to-1 ratio, but we staff a little bit higher than that, just so we can have some protection. By having this in place, you provide a little bit of backup so that if it's not because we're not giving carte blanche to say, oh, just ignore the other patient when you're busy with one. No, we're not saying that. But there is a little bit of relief when you know that there's one more way that we're following the patients. And so this is just a number of references that have shown that there's been significant increase in nurse satisfaction and nurse retention. It's very expensive to recruit and retain nurses, and if you don't have to do that as often, and it's been shown that there's about, on average, more than a 30% decrease in nurse departure from the unit, so an improvement in nurse retention. And there's other financial examples. In this particular study, it's a little bit busy, but it showed that there was a Price Waterhouse firm that reviewed the implementation, and they recovered all of the money that they spent on the capital and the financial for the doctors and nurses to run the system within the first year. So there's lots of goals, and essentially it's improved quality, safety, efficiency, and capacity. Secondary goals are to do things like make it more fun again. With the EMR that we put in, what did that do? That took us from the bedside. It's caused immense increase in stress and burnout amongst doctors and nurses. This does not fix it, but it helps a little bit. It helps provide, it's been shown on some studies to help provide a little bit more relief from the angst and buy-in. So this, you go through and you make sure all the patients are on the evidence-based protocols, that they're getting all the things that they should be on, and if for some reason the doctor didn't write it, this is just one more scan of the system, and then the team can actually write the orders and put them on the protocol. So it helps quite a bit. So what are some of the enhancements that we have in mind? So we are partnering with the engineering team here at UC Irvine. We also have some partnerships and involvements with outside disruptive companies that work on devices and so forth. We are very interested in wiring all of our patients with some of the newest and coolest things. I won't mention the names of some of the companies, but one of the things that patients do not like in the ICU is their loss of autonomy. Another thing they do not like in the ICU is when they get tethered down. And so the more that we can let patients move a little bit, but still capture that data and it comes into this automatic system, those are things that we're looking at. We already measure end-tidal CO2, but there are other molecules that we can measure in the exhaled breath that we're looking at for monitoring patients. We have one of our research scientists, Elliot Botnovic, who has developed a continuous lactate monitor system. So instead of needing to just wait a half an hour to see what the flow is, you can just continuously monitor how that patient is responding. And when a patient is in shock, what is one of the things you're looking at? Certainly heart rate, blood pressure, urine output, and so forth. Urine output on more of a every 30-minute or hourly basis, but lactate, if you can get that on a minute-to-minute, if you're reinstituting perfusion to the liver and the patient is being resuscitated, those lactate clearances are very helpful. So we're looking at that. Genetic analytics as well. Now that we have the ability to parse portions and increasingly evaluate and interrogate the genome, we know some patients are going to be more sensitive to certain disease entities, so we can rule those out quicker. We know that we can do sequencing of whatever the organism is that may be infecting them, and we can get that answered, within hours instead of within days. And so we can now target the antibiotic therapy. So all this information now is coming through that computer intelligence into our system. We think that this particular system so far is one of the most robust, but it's probably not as good or as smart as Charles and Lisa, and they're going to talk to you about some things where we envision that we would overlay the ClearSense work that we're doing. You'll hear more about that later for early warning, early deterioration upon this chassis. We also have some very innovative big data thinkers, Mike Knowles, who is at the NIH, and Faraz Faghri, who have developed systems and algorithms for machine learning that can use the data of the patient at a much higher level than comes out of the box with this company. So we're going to have our UC Irvine, health explanation point addition to these systems. Where can you find this currently? There's a number of places throughout, mostly on the East Coast. When, I don't say if anymore, now it's when, and I'll show you our timeline in a moment. When we put this in place at UC Irvine, we will be the first academic center west of the Mississippi. Now I put Barnes-Jewish because they just put this in place recently, and they're on the Mississippi, but we're still gonna consider ourselves west of the Mississippi. There are others that are looking at this in California. Sutter and John Muir has had this in place. They have a little bit older systems, go back to that. I showed them up here. They were for a while monitoring St. Joseph's, but it's an older system, it's not being used anymore. If you fly over California, it's mostly all rural, really. If you think about it, it's mostly all, with the exception of San Diego, right on the coast, LA, San Francisco. Yes, we're starting to fill in some of these other areas, but still, when you fly over, there's a lot. So there's a lot of areas that have small centers that if they deteriorate, you need to put them into a helicopter or into an ambulance and send them in. And we're not saying don't do that, but what we are saying is if they do go to those hospitals or smaller clinics and so forth that are in rural areas, that we can enhance the management until care can get to them and they can come to a higher center, or maybe you can turn it around quicker so they don't actually have to deteriorate. Furthermore, if you think of just loss Los Angeles itself, there are a number of small hospitals that have no intensivists. There's nobody there in the evenings and weekends. It's like a desert in terms of really good doctor nursing care at night sometimes, and we can help some of those hospitals also. So not just LA, but San Bernardino County, Riverside County, there's a lot of areas that need help. And so I'm a California native, and I'm sort of California-centric, though I did my medical school training in Philadelphia, and some of you may hail from other parts of the country, but what I'm showing here for California being mostly rural is really true for all the states. If you fly over and they're mostly rural, and then they have pockets of really congested areas, and within those pockets, you can go through each of the inner cities. They have hospitals that need this. Hogan, Orange County, there's Dr. Afable, who is thinking about this as well. They've already identified 85 hospitals in Lubbock, Texas, where they want this to happen. UCSF and John Muir are thinking about this. There's a company called Advanced ICU, and I'm going through these slides kind of quick because they're just like overview. There's things happening out there. Mary Jo Gorman, who founded this company, now has turned the reins over to Lou Silverman. They have monitoring cores for e-ICU in New York, St. Louis, Honolulu, Tel Aviv, India, and they just put one in Irvine over by the John Wayne Airport about a year and a half ago. I've visited their center 3 times already at Irvine. They use the Philips model. They use it out of the box, but then they rent it to people. So if you want, whenever you have a middleman, it always causes the price go up, right? But your initial ability to get into the market is lower. So that's their business, okay? So, if you happen to be in a place where you can't quite afford the initial, then this might be an option. And they have developed some of the things that I talked to you about, what we're doing at UC Irvine in terms of enhancing, they have done some of that work already. But we can't take theirs, it's proprietary, so we have to do our own. We're negotiating with UCLA to do this, but UCLA, so what we're gonna do, I'm gonna show you our system in a minute. At UC Irvine, we're gonna monitor our internal patients and then do the outreach. UCLA only wanted the outreach. And the reason they did that was because, and there may be some people from UCLA here, so I apologize, but UCLA was, had the philosophy that they're so good they don't need to monitor their own people, they just need to do the outreach. Well, the truth is, the outreach is very lucrative. But if you don't monitor your own people first and get that system up and going, then you're not doing as much good for the public, because the patients really would benefit at every single one of our 5 University of California hospital centers. This is just that. This e-ICU company has only one hospital in California that they have a contract with. They do most of the work outside of California, it turns out. And they just lost that because Dignity Health bought it. They were contracting, negotiating out with Davis, and Davis also wanted only the outreach. Okay, so the outreach is very lucrative. But I just showed you a moment ago the data from 2017 CHEST that shows you that even the hospital itself doing the internal work can be financially viable. So there's other big hospital systems, Dignity Health. Lloyd Dean, who's the CEO, is a big supporter. He hired Dr. Bhatia to oversee their 1,400 ICU beds. Banner Health has been in this market already for some time. In 1 year alone, they said they saved $68 million. So what's our plan at UC Irvine? First, we want to improve the quality, safety, and experience of all of our patients at our own hospital first. We want to decrease mortality, length of stay, and costs. Next, we want to increase the quality of critical care in surrounding communities and partner with them. And in so doing, we also have, we want to expand the UC Irvine brand and image and so forth. And we think that by taking great care of our own patients, improving the care of the surrounding communities, then that work will speak for itself. So this is just a slide that shows that we've been, increasingly full in our ICU. And if you do the math on this, according to the number of beds, number of ICU cases per year. Remember I showed you the data from UMass where they had about 4,700 a year. We have about 4,500 or so a year here. And if you decrease the length of stay in the ICU and on the floor, you can get avoided ICU and floor days. And what this adds out to is somewhere in the range of, conservative numbers, 14.5 to 20 beds are created. So to create one new ICU bed in Orange County is somewhere between $1.5 to $3 million. So if you build a new building with it, it's about $3 million. If you're able to convert rooms in an existing building, it usually runs around $1.5 million a room. So right now we're full, we need capacity, so that's one of the reasons we're gonna put this in. So I've wanted to do this for a couple years because improvement, quality, and safety, but now that I've been able to convince our Chief Operating Officer and our Chief Financial Officer that is also going to create beds for us, which is a big, problem. Now we have full agreement to get this moving. So pictorially, we're talking about having our command center in the vicinity of the hospital, but not directly in the hospital. We'll monitor ourselves, we'll monitor other community hospitals and critical access hospitals. This is a map of overlying the Los Angeles area that shows the blue dots are critical access hospitals, like Catalina Island, Lone Pine, all of these different places where, up in Big Bear, where patients can be put temporarily, and it's a long distance and takes like an air flight or, a 1 or 2 hour drive to a bigger hospital. And so if you can provide some oversight and help there initially, then there's probably some opportunity. So in our first phase is going to be a 24/7 nurse coverage model with the MD coverage in the evenings, weekends, and holidays. And then we'll move to a 24/7, the nurses will always be 24/7, but we'll have the 24/7 physician model soon thereafter. And this is a busy slide, but this one here provides a timeline. So we'll probably be finalizing contracts in September, October, and then more of the planning, though we've done a lot of that for a couple years. And it'll take us about 6 months to get everything up and running, everybody trained and executing and activated. So we're talking about July of next year of go live. This is a little bit of a busy word slide. I won't take too much time, but I will just show you this, which after we have it up and running for our internal structure, then we're going to move it out to outlying hospitals. And this is a list of the hospitals that tend to transfer us the most ICU patients. So we'll be reaching out to them first. I've had some preliminary talks already with Mark Uffer, the CEO at Corona, who's very excited about this model, and I've had some talks with some of the CEOs, chief operating officers, chief medical officers at some of these other hospitals as well. So we're going to expand the coverage. There's also, I didn't mention telestroke and the ED benefits as well. This is an image that shows you kind of a dashboard that comes out of the box. It helps you do your door to needle time and so forth, so that's beneficial. But this slide here really demonstrates the entire spectrum of hospital to home. So you can monitor patients in the ED and the ICU as they leave the ICU into step-down units and so forth. And of course, we also have a number of satellite emergency departments that will deploy this in, both for telestroke as well as for monitoring patients before they're able to come to us, while they're getting worked up and so forth. And this will serve as a backbone of our hospital to home. When patients at home, they can just get on their laptops or on their even computer phones and so forth, and and check in with a smartphone. We can have vital sign data for those patients. They can go and take a picture of their leg ulcer and how that wound management is going and so forth. So we have a number of other telemedicine initiatives that are going on, but we're going to use this as a backbone and central hub for all of that. So, that's really the story. And I know there's quite a bit, and there's a lot to digest, but that is the full e-ICU vision that we have planned for UC Irvine, and I thank you for your attention.